Okay, so we are here today on behalf of Power to the Patient, a patient advocacy group that educates women on their healthcare choices, and we're talking to our medical professional, Dr. Tammy Epi, on questions relating to women's health.
Well, good morning, Tammy. How are you?
Hi, girls. I'm so glad you came by the office today. I know there's a lot of questions that all women seem to have, questions for their doctors, and sometimes they're too uncomfortable to ask those questions face to face. So we're going to try to address some of those issues here today.
Awesome. Okay, so I have one question, and I know I'm probably cutting you off, but is there any truth to the fact that women will say there is an age cutoff before you can have a hysterectomy? You have to be of a certain age.
Well, that's a really good question, Jess, because a lot of women do have that misconception that there's a cutoff. Like if I'm 30, there's no way I'm going to have a hysterectomy, and I have to wait till menopause or premenopause. And that's just not true. But it is completely individualized, patient to patient to patient. So somebody that's in excruciating pelvic pain, that has either completed her childbearing or knows she does not want to bear children, at any age, basically, she could be eligible for a hysterectomy. And at the same time, some women are begging for a hysterectomy, but they really truly have no medical indication for it at any age, and so you would try to advise that patient to think of other ways and alternative treatments avoiding hysterectomy. So there's no magic age.
Okay. So is there a particular reason why you should avoid it?
Well, if you really don't have a true indication that is a symptom arising from your uterus or your cervix or your tubes or your ovaries, there's really no reason to remove those organs, because you might still feel exactly the same after a hysterectomy as you did before the hysterectomy. But if there are symptoms related to any of those organs or all of those organs, a hysterectomy can be completely curative. So once again, it's individualized.
Okay, cool. So what if I know I don't want to have children? I'm 27 years old and I don't want to have kids, not married, and I want to get a hysterectomy to be sure that I'm not going to have kids. Do doctors do that?
Well, let me answer that a couple ways.
Okay.
No. Most doctors would not even consider doing that just because you don't want to have children. But the reason for that is we have such great long-acting contraceptive devices now, such as IUDs and injectables and shots and patches, and of course birth control pills and tubal ligations, and all sorts of different options for patients, but in particular the long-acting contraceptives that are reversible, but usually once you insert, for example, an IUD, you're going to leave it in place for 5 to 7 years, and at that end of that time, a patient that's still in the childbearing age group might have changed their situation or might have changed their mind. So you really don't want to eliminate that possibility forever for a patient. Now, if there's an indication other than just not wanting to ever have children that the hysterectomy would be valid for, then that's up for discussion and consideration. But just for the indication of fertility versus non-fertility, it's not an option for that.
Okay. So I had a hysterectomy, but I still have my ovaries. Now, granted, I'm old and I don't want any kids, but if I wanted to give an egg away, or perhaps sell one because I was short of cash, can you still harvest my eggs?
Well, it depends on your age. So when we go through menopause, we are no longer producing eggs. And the average age of menopause in this country is 50 to 52. And the main clue that women get is their period stops, and once you've had no period for a year, then you're in menopause. Well, women that have had a hysterectomy maybe don't know, well, I don't bleed anymore, I don't have a monthly cycle, so how do I know if I'm even in menopause? So there's blood testing you could do to see if you're still producing eggs and ovulating, if your ovaries are functioning. If your ovaries are still functioning, yes, then you are qualified to be an egg donor. But it's usually egg donors are more desirable when they're younger, in their 20s to 30s, because those eggs usually are more DNA intact and have less chance of having some genetic abnormality just due to the age of the egg. So it's possible. And that's another thing too. A lot of women out there think that a hysterectomy means, okay, I'm hollowed out. There's nothing left in there. My cervix is gone, my uterus is gone, my tubes are gone, and my ovary is gone. A hysterectomy simply refers to the cervix and the uterus itself. Sometimes we do hysterectomies that are called supracervical, where you leave the cervix intact. And in certain situations, that's a good thing for a patient. And you just amputate the body of the uterus and remove it for the hysterectomy. But generally speaking, a hysterectomy simply involves the uterus with the cervix. If you include tubes, that's called a salpingectomy. If you include ovaries, that's called a oophorectomy. So there are all these different add-ons to the hysterectomy, but hysterectomy itself only refers to the uterus with or plus or minus the cervix.
Okay, so a younger person then, say someone who medically needed a hysterectomy in their 20s, not elected to have a hysterectomy in their 20s,
Right.
They could do something with their eggs and a surrogate or something like that.
Oh, absolutely, because they would still have their ovaries there ovulating on a monthly basis, and if they went and saw an infertility specialist, they could have their eggs extracted, frozen, kept for later, or at the time removed, and through the process of in vitro fertilization still could use a surrogate and have one of their own genetic children.
Okay, which then this is just sort of an off-topic question. Are we really born with all the eggs we're ever going to make?
Yeah, we are. And as a matter of fact, this is fascinating. When I was in medical school and studying embryology, I thought this was like the coolest thing ever. A female fetus has the most eggs that she ever is going to have, and in her entire life at around the 20-week gestation period. Starting at 20 weeks, when you're still in your mother with 20 more weeks to go until you're born, your eggs start, it's called atresia, they start dying off. So when you're born, you have already a decreased supply of eggs that you're going to have for your entire life. But those are the only ones you're going to have. You don't make more eggs throughout your lifetime. As a matter of fact, the eggs die off and become, imperfect over time. And then eventually they just stop being made at all, or being ovulated at all. And all the eggs are holding in one of the first stages of mitosis, which is kind of a cool thing too, to think that they're sitting there and holding in this process that usually is a continuing thing. Unlike males, where they're not born with sperm, and they don't start making sperm until they go through puberty. And then they continue to make sperm until the day they die. But their sperm quality tends to diminish, and there's issues with that too, of course.
Three tails, two heads.
Exactly.
Crooked swimmers.
Not exactly normal, the ideal, but yeah, that does happen. But yeah, I thought that was really a cool thing that you're born with. That's it. Those are your eggs.
Yeah. That's really interesting.
Yeah.
So is there any way to tell, like she was saying about harvesting the eggs, if you're over 40, if the DNA is intact and all of that stuff, if it's a healthy egg, or?
There are certain genetic tests they put the eggs through to look at the DNA of the eggs to make sure. Yeah.
Okay.
So that is something that's done. Wasn't always available, but as the science and technology have evolved, that is something that they do. And they're even looking now to try to correct genetic defects in the DNA with people that know that they have certain inherited traits. So that's a new field being explored also.
So you have to be ovulating the eggs in order to harvest them? Even though you're born with them? Do you have to be ovulating them to take them? Or can you take them out of your 10-year-old?
No, you can't take them out of the 10-year-old, but what you do is you stimulate the ovaries to produce the follicles, which will then release the egg. So anybody that's going to have eggs retrieved, they're put on medication to stimulate the ovaries so that multiple follicles will go and develop, and then through the IVF procedure or egg retrieval procedure, the eggs are then taken out of the follicles.
Okay.
And there's always several taken because you never know if they're going to survive, you know, in the process. So you generate a harvest of eggs.
Cool. Well, that was really neat. Sorry, I know we kind of got off of what we were supposed to talk about, but
That's okay.
that was one of those questions I always wanted to ask.
Yeah. It's fascinating.
It is.
It's
That's
a whole
really
field of science
interesting.
that's really only been around, you know, a short time relative to humanity.
Now, some women say that they've had their tubes tied.
Yeah.
And they still get pregnant. Is that possible?
That can happen. It's rare. Otherwise, we wouldn't offer tubal ligation as a means of, you know, for sterilizing a patient. But all the tubal ligation procedures do have a failure rate, but it's low. So it doesn't matter whether the tubes are burned or clipped or rubber banded or a tubal segment is excised or the whole tube is removed. There's always still an oddball chance, that somebody could get pregnant. Also, your chance of an ectopic pregnancy goes up when you've had your tubes tied. In the rare event that you did get pregnant, you have a higher chance that the pregnancy would be outside of uterus itself and hung up in a tube somewhere. Because think about how pregnancy occurs. The eggs have to travel into the tube or somehow through some defect in the uterus to meet with the sperm in the middle and form the embryo. So that if your eggs are free floating out here and the sperm makes it up through the uterus, that somehow that fertilized egg could implant somewhere outside the uterus.
Oh, wow. Which then leads me to another question. When you take out my uterus and my uterus and my cervix, or just my uterus, and I still have my ovaries in there, where do my eggs go?
They just dissolve as they always do when you ovulate and don't get pregnant. So every month, once we go through puberty and start ovulating and having our menstrual cycle, the egg comes out of the ovary. It can be picked up by the tube and travel down to the uterus and either dissolve or be evacuated when you have your menses, or it just sits in the abdominal cavity and just dissolves. That happens every single month with us from the time we start having periods till we go through menopause. So no, there's not like a stockpile of eggs that just kind of build up like
Gumballs?
Yeah, like people think it's like caviar, you know, all those eggs like hanging out there. But no, they disappear, just undergo atresia, just go away.
Cool.
Can I ask about dermoid cysts?
Oh yeah, those are cool.
Okay.
Are those the ones with the things in them?
And the hair.
Oh,
and
they
the,
are. They are.
Is that another human that's in there
Well,
that just died or something?
These are part of the normal cells because they're made up of normal cells in an abnormal place. So when life is forming in the uterus and a lot of your cells are determined to go to different parts of the body, sometimes some of these cells get trapped in the ovary. And based upon what those cells are, they can produce hair, teeth, bones, a very nasty looking cottage cheesy material.
Dermoid cysts.
Yeah, and a mucinous kind of thing. And sometimes you find brain, you find neural tube tissue, all kinds of interesting things in dermoid tumors. They are benign. There is a rare instance of malignancy in dermoids, but only in certain types. But generally, dermoids are considered benign. They occur in both ovaries a certain percentage of the time. So, you know, if you have one, make sure your doctor looks at the other ovary at the time of surgery. And you know, they're cured. You just take out the dermoid. You try to take it out intact, but many times they rupture. You just make sure that everything's cleaned out, nice and tidy when the surgery's done, and you're cured. But they're very fascinating tumors. A lot of people think, oh, it's my twin. No, it's not your twin. It didn't evolve. It's just normal cells that shouldn't be in the ovary. They are there and they just take off and grow. Under what stimulation, nobody knows, but it happens.
So, speaking of twins, is there any truth to that I ate my twin in the womb thing?
Well, not that you would actually eat, but that does happen quite a, not a lot, but you do see where twins are conceived, and over time, one of the twins will either resorb or fail, stop developing. There's lots of different reasons. If you are, the two babies are in the same sac, then there's more chance of them getting entangled in each other, and one of the baby's cords could be, cut off, blood supply to the baby. So you do see things like that, but it's not that common.
Huh. And then it turns into a dermoid. Okay. What are the ways that a doctor can perform a hysterectomy?
Oh, that's a great question, Retta, because, when I trained, it was the late 80s and early 90s, and there were two ways to do a hysterectomy. Either it came out the vagina or it came out the abdomen. And through the abdomen, it was either an incision like a C-section across or up and down based upon the size of the uterus. And it was very clear cut who got vaginal hysterectomies, who got abdominal hysterectomies. Then we started to have innovation in techniques, technology, instrumentation, and that spilled over into our laparoscopy, because gynecologists have always done laparoscopy for diagnostic reasons. Look in through the belly button to see if there's something diseased in somebody's pelvis, or if somebody is infertile, is there a reason that we could correct with laparoscopy? But we didn't have the proper equipment to do bigger procedures. But over time, companies developed techniques and instruments that we could use and do bigger operations like hysterectomies. So that was a really exciting thing that came about like in the early 90s. So by the time I finished training, I was already behind, because now certain places were doing laparoscopic bigger cases, whereas wherever you train, you might not have even been exposed to that. But we all learned as we got out into our practices. And now, of course, the robot has been around for over 10 years, and that's an extension of laparoscopic surgery. It's thought to be a tool that can aid some physicians in more difficult cases, or when they're struggling with their basic laparoscopy skills. The robot could really be very helpful in certain things that they find to be really arduous in the procedure, like suturing or tying knots. The robot can be very, very useful for that. So we have robotic, we have laparoscopic, we have abdominal, and we have vaginal. All possible routes for hysterectomy.
Is there anyone that gives a quicker heal time?
Well, anything that's done through smaller incisions, usually the patients recover a lot quicker. So the one that takes the longest to recover from would be an abdominal incision, just by virtue of the fact that, your belly has been cut open. And it just takes longer to heal. There's bigger amounts of tissue that have to heal, and it just takes longer. You're usually in the hospital a few days longer than you would with a laparoscopic or robotic procedure. Robotic and laparoscopic procedures, patients usually go home, some the same day, but most within 24 hours of the surgery. And you're asked to really kind of take it easy on your activities for a couple of weeks till you've had your post-op visit. And then you're pretty much back to normal. But with abdominal, you're asked to be on restrictions for up to 6 weeks, just like with the C-section. Women can't just jump up and start exercising and doing things for a period of about 6 weeks.
Okay. Let's talk about fibroids.
Oh, that's a very popular topic, and really a widespread problem.
Aren't they little? Well, tell me what they are. So I could guess all day.
Fibroids are tumors. Tumor doesn't mean cancer. Tumor just means growth. So fibroids are growths, and they are benign. There's a type of a tumor called, I'm blanking on the name right now. Anyway, that is malignant, and it mimics a fibroid, a sarcoma. A sarcoma of the uterus looks like a fibroid on the surface, and sometimes it can be confused with a fibroid, but fibroids are benign. So fibroids, they're so unique. They start from one single muscle cell, and the uterus is made up of mostly a muscular layer. So the big, thick muscle wall that contracts to give you menstrual cramps, that contracts to expel your baby in labor, those muscular cells are just lining the whole wall of the uterus, and just one goes haywire and starts to monoclonally multiply itself. And this can happen just once with one fibroid, or it can happen 100 times, and somebody could just have a uterus that's littered with fibroids. They are benign, so if you have a fibroid or two and they're small and they're not causing any symptoms like heavy bleeding or abdominal pain or pressure or huge size in your abdomen, you can just kind of watch them and just follow the patient along. And sometimes when a patient finally stops ovulating, goes through menopause, sometimes the fibroids resolve, shrink, and your symptoms go away. But other times, they do not. And it's a very, very common cause of women requiring hysterectomy, the fibroids themselves.
And there's all different kinds, right?
There are. You can have fibroids inside of your uterus, but you're usually taken care of through procedures like laparoscopy, but it's called hysteroscopy, where you take the scope and go up into the cervix, look in the body of the uterus, and then remove the tumors just by a scraping kind of procedure. The tumors can exist within the wall of the uterus or on the surface of the uterus. And those are the ones that require either a hysterectomy, or in a woman that desires to keep her uterus for either future childbearing, or she just wants to keep her uterus, you do a procedure called a myomectomy, where you just remove the tumors themselves and just repair the uterus.
Interesting.
Yeah, it is. It is. And they're fascinating, and they can look horrible. Tumors on the uterus can really mouth shape the uterus to where they are huge. I've seen uteruses up to the diaphragm, filling the entire abdominal cavity. And when you remove it, it looks almost like an alien structure, just with all kinds of things that look like potatoes adhere to what's a teeny tiny little uterus. Crazy.
So what's a D&C?
A D&C is that stands for dilatation and curettage. So D&C is done for a whole lots of reasons, but most commonly for abnormal bleeding. So under anesthesia, you dilate the patient's cervix so that you can get the opening to be large enough to pass instrumentation in there, which are curettes, and then you scrape the uterine lining. It's done for diagnostic purposes, like if you're worried somebody has cancer and they're having abnormal bleeding and you want to get a really good tissue sample, you would do a D&C, or a biopsy in the office, which is basically the same thing. And other times it's curative, like if you know somebody has a polyp in their uterus, you dilate and you curette the polyp, or the little fibroid could be taken care of that's growing on the inside of the uterus.
But it's not the same thing as when you go in there and get all those fibroids, though.
No, that would be like a separate thing.
Okay, cool.
Any more questions?
I don't know. I feel like I'm learning so much.
I know.
Well, the key is always, when you go in for your normal GYN checkups, don't be afraid to ask questions. And every doctor should be prepared for questions. And in this day and age where, as patients, we feel like we're being, run through a mill, like 2 minutes, let's go, what's going to come on, hurry up, what are you concerned about?
Yeah.
And we get flustered, and plus, our type of exam we undergo as a female is kind of embarrassing, and like your mind kind of blanks out. You just want to get the exam over with. But make sure you take the time, and if you need to, write down your questions before you even get there, so that when you're blanking out in the middle of a pelvic exam, you can refer to your questions and just make sure you're satisfied with the answers. And if your doctor really isn't willing to talk to you about options, about particular problems, different approaches, then maybe it's time to kind of shop around and check out different physicians. If you like the things you're hearing from your doctor, great, have confidence. You can always go online, research them, come back with more questions. But the flow of conversation is really vital to the doctor-patient relationship, and we should not be afraid as women to not speak up and get our questions answered.
Well, Jess and I and Phyllis, who you'll meet in the future.
She's over there off camera.
Yep, that's
She
who we
did the
keep looking
intro.
at.
Came up with an app.
There she is. That's Phyllis.
She's being antisocial today. We came up with an app called the 300 Club Power to the Patient app. And you can download this app. You can put in your zip code, and it'll give you one of the doctors that we think is a great doctor because they've turned in their data. They've done a lot of stuff that Amos, we'll talk about that later too, has offered them, has requested from them. They've turned in a lot of data that a lot of us need to see before we go in and talk to our doctors. So be sure to download that app. And thank you.
Thanks for your attention, everybody.
Thanks, Tammy. Next time, let's have wine.
Yes, please. We'll take wine over coffee and water any day.